My name is Tyler CRAM. Here I present a case highlighting the use of the cryopreserved viable osteochondral allograft for the OCD of the capitellum. Osteochondritis dissecans of the capitellum is a well-known disabling condition of the elbow that primarily affects the dominant arm in athletes aged 11 to 21. Overuse with poor mechanics and overhead sports has been described as the major culprit of OCD lesions. However, lesions can also be caused by acute trauma. Lesions are often classified as stable or unstable. Stable lesions can often be managed non-operatively. However, patients that do not improve clinically with rest and activity modification or unstable lesions will typically require surgery. Many different operative techniques have been described and are often determined by the size and depth of the lesion. Osteochondral autograft transplant has been popularized particularly for large laterally localized lesions, which have been shown to have higher contact pressures compared to smaller, more centrally located ones. While these grafts have been shown to provide benefit, the autograft harvest comes along with the risk of donor site morbidity. Cryopreserved osteochondral allografts, or CVOCA, have recently become available with one major advantage of being available off the shelf without the risk of donor site or harvest complications. It also contains a layer of full-thickness articular cartilage with a thin layer of subchondral bone that includes chondrocytes, growth factors, and extracellular matrix to help induce cartilage repair. Here we present a case study of the use of CVOCA, or cardiform graft, for OCD of the elbow. Our patient is a 15-year-old right-hand dominant male who presented with right elbow pain and decreased range of motion approximately 3 months after a crash while BMX racing. He reports having some initial pain in the elbow, but denied any swelling. However, over the following months leading up to his initial evaluation, the patient states that his pain and range of motion had progressively been getting worse despite conservative treatment, including rest, ice, compression, and therapeutic exercise. Here in Figure 1, we can see preoperative radiographs of the right elbow, demonstrating lucidity of the lateral aspect of the capitellum, as well as a large intra-articular loose body. In Figure 2, we can see preoperative MRI images of the right elbow, demonstrating an OCD lesion of the capitellum with subchondral edema, as well as a large loose body in the posterior aspect of the elbow. Due to failure of conservative management and findings on X-rays and MRI, decision was made to take the patient to the operating room. The patient was placed into lateral decubitus position. On arthroscopic evaluation, a large fragmented loose body was found in the posterior aspect of the elbow, as well as a large OCD lesion of the capitellum that extended laterally beyond the edge of the native cartilage. For this reason, it was felt that microfracture or biocartilage type procedure would have poor results, and decision was made to use cryopreserved osteochondral allograft. The posterior pores were extended to convert to open procedure. A knot with suture tack and 2 push locks were placed to secure the implant to the base of the lesion. The elbow was then raised to ensure stability, and no blocks of motion were noted. Once stability was confirmed, the joint was irrigated and the wound was closed in a layered fashion. The patient was placed into hinged elbow brace. The patient tolerated the procedure well and started physical therapy immediately post-op and was able to begin range of motion exercises as tolerated. His post-operative course was uneventful. An MRI was obtained at 3 months post-operatively, seen in Figure 2, which demonstrates evidence of incorporation of the cardiform graft to the underlying subchondral bone. At 6 months post-operatively, the patient is pain-free with physical therapy. Elbow range of motion has improved to 125 degrees of flexion and 5 degrees short of terminal extension. This case highlights the novel use of a viable off-the-shelf cartilage implant for OCD of the capitellum. At 6 months post-operative, the patient is pain-free with significantly improved range of motion. Fresh osteoarticular autograft procedures have been used for treatment of OCDs with good results. However, this comes with the risk of donor site morbidity. Knee donor site morbidity has been reported up to 8%, whereas rib osteochondral autograft donor site morbidity is lower at 1.6%, but includes a risk of harvest complications. In addition to no donor site morbidity or harvest complications, the CVOCA or cardiform also has the advantage of a 2-year shelf life and is more cost-effective than fresh frozen allografts. While the cost is similar to that of the particulated juvenile allograft cartilage as seen in de novo, these do not include a layer of subchondral bone and do not have zonal cartilage orientation, thought to be important for long-term outcomes. In conclusion, this case study demonstrates good short-term outcomes of a cryopreserved osteochondral allograft for osteochondral lesion of the capitellum. Advantages of this graft include off-the-shelf availability, no donor site morbidity, and better cost effectiveness for smaller lesions when compared to fresh frozen allografts. However, our study is limited to a single case. Future research should include larger cohorts with adequate short, middle, and long-term outcomes to assess the viability of these novel grafts for OCD of the capitellum.